Welcome everyone to the Jobskin webinar on compression for scar management. My name is Adam Ho. I'm the Managing Director of Jobskin Australia and New Zealand. With us today is Rosemary Kendall, our Clinical Advisor based in WA, as well as Veronica Eichmann, our Clinical Advisor based in New Zealand. With that, I will hand you over to Rosemary.
Thanks, Adam. And those of you who are on the call will know that Veronica wanted me to remind you that if you didn't pre-register for the webinar, while you are absolutely welcome, we would love to send you a certificate, a PD certificate for being here. So if you could just post your email address in the chat, then Veronica will have your details, and she's the one who's organising those certificates. So I'm not sure whether you can see me. There is absolutely no need to see me. So Veronica or Adam, can you let me know whether I'm visible or is it just the screen?
Yep, you're visible.
Oh, I don't know how
Rose, we can definitely see the screen. You're just like a little thumbnail down the bottom.
Yeah. Okay, so well, I just hope it's not intruding on the screen. I mean, you know, if I'm seen, well, so be it, but I just don't want it to get in the way of the slides. But look, welcome everybody. As Adam said, we're glad you've joined us, and we hope that this is going to be practical and useful for you. I'm guessing that we've got a range of levels of experience for people who are on this webinar, and forgive me if I'm going over basics that you're familiar with, and if you feel like that we're skipping ahead or there's something that's you're not quite following, please do put a comment in the chat, or by all means unmute yourself and ask. That's totally fine. But if you do put something in the chat, Veronica will just interject on your behalf. So whichever you feel more comfortable with. So, oh, that shouldn't actually say module 2. It should say webinar 5. Slight little glitch there. I'm not quite sure what's happened. And I'm thinking I might actually just check that, yes, I am in the right one. What we're going to cover today is a little bit about scarring, because some of you on the call, on the webinar, may not feel entirely confident with scarring, and identifying scarring absolutely informs our clinical decision making for compression. We're going to talk about a few practical guidelines, talk about prescribing correct compression, and then we'll talk about Jobskin custom garments. I'm going to leave out the bit of care and maintenance because I think we're out of time, and likewise for donning and doffing. What I've done just this morning, I've just changed it up a bit to include handy hints, some of which, if you've been on some of the other webinars, you'll see that there is some duplication, and that's deliberate because each of these webinars is a standalone topic, and we can't really assume that you know things. So do bear with us if you feel like there's a little bit of repetition, but I do know that a number of you registered have not necessarily been at other webinars. So just let's start at the beginning, to quote Sound of Music. Like, what is scarring? And I think these are quite helpful stats for us to, or information and stats to keep in mind. The first thing to remember, and that we often need to remind our patients, is that a scar is a normal and inevitable outcome of tissue repair. And that's something that's very challenging these days because we live in a society that is very focused on appearance and perfection. And so scarring is difficult for people to confront. However, it is normal, it is inevitable. And there's an article, I haven't found a more up-to-date equivalent, but I do really love this quote because I think it really helps set perspective. And that is, as you can see on the screen, each year in the developed world, this is in 2003, 100 million patients acquire scars, some of which cause considerable problems. Of those, 55 million are attributed to elective operations and 25 million from operations required because of trauma. There are an estimated 1 million keloid scars and 4 million burn scars, 75% of which occurred in children. these are old stats, but I think it's helpful for us as therapists in approaching patients and helping them understand the normality and the inevitability of scarring, but that our job obviously is to give them the best possible scar out. Quick scarring 101. The whole term scarring covers a wide range of clinical phenotypes, and apologies, but these are stock images because it's easier with some of the consent, you know, the need for consent with these images, but these are quite representative of the range of scarring that is included in those clinical phenotypes. So the first one on the left is fine line scarring, and these are most likely caused by surgical incisions or lacerations, and also self-harm. And generally, self-harm is a little bit different because self-harm often moves over to category 2, but we'll talk about that in a sec. The fine line scarrings generally mature within 3 to 6 months without any drama or necessarily need for intervention, unless they become what we call a stretched or a widespread scar. And this generally occurs when scarring is under tension. So I actually have got a beautiful photo that I use in-house doing education with within the hospital I work in, but I don't have consent, unfortunately, to use that in a wider context. But it's a scar that is almost along the line of the clavicle. And when I ask people what they think caused this scar, because most of it is a fine line scar, but then there's one section about 5 centimetres that it is very wide, and almost everybody would say, oh, the wound dehisced. But in fact, that's not the case. It was because the skin was under tension. And so even though the wound healed without adverse events and without dehiscence, it has converted to what you're seeing in that second photo there. It's become a widespread scar in that one section because of the movement of the head and neck. There was that constant tension. We see widespread scarring often on shoulders and knees. They're the most common because of the range of movement in those joints. And we also see widespread scarring in self-harm, not because the skin is necessarily under tension, but because the oftentimes self-harm lacerations are not repaired. They're covered up, they're hidden, and so they heal without the two sides of the incision being joined together. So the third type of scarring is atrophic scarring, and that's a close-up of a face, and I'm sure you would immediately draw the conclusion that they're of the two main causes, and they are generally chickenpox and acne more so. And most commonly, or in my clinical experience, these scars, we as therapists have very little to do with them, partly because when people present with concerns about this scarring, the scarring is already mature. Because at the time that people have acne or chickenpox, they're concerned about the acne or the chickenpox, not about the scarring. And so frequently they need a surgical dermabrasion. Fourth type of scarring is hypertrophic scarring, which I'd say most of you on the call would say this is why we're here, hypertrophic and potentially keloid scarring. And that's just an acknowledgement that all of those images are from their Getty stock images. The main difference, or there's two main differences between hypertrophic scarring and keloid scarring. Hypertrophic scarring can be raised, red, itchy, firm, but it remains within the border of the wound and it follows a predictable timeline. So usually a hypertrophic scarring, that scarring process amps up about the 6 to 8 week mark, and then it can escalate up to a period of 6 to 8 months potentially before it then starts to subside with intervention. Keloid scarring is also red, raised, firm, itchy, painful, but it's redder, more raised, firmer, more itchier. It's kind of like hypertrophic scarring on steroids, so to speak. But the other two clear clinical differences are that keloid scarring does not remain within the border of the wound, and it doesn't follow a predictable timeline. So the scar can become keloid at any time, really, and also that scarring process doesn't spontaneously regress. It may continue to escalate. As an example, I am seeing someone who is has had 2 small mozzie bites on her chest, and she now has like a bow-shaped scar because each of those 2 very tiny bites have become large, almost the size of a bow tie, but sort of plopped between her breasts. It's completely disproportionate in size and totally disproportionate to the incident or event that caused the scarring in the first place. And the reason it's so important that we distinguish between hypertrophic and keloid scarring is that their responsiveness to conservative scar management and actually to surgical or injectables is vastly different. Now, I'm not going to go on about this at length, but just to kind of set the scene for the histology of scarring. In normal skin, collagen fibres lie flat with a loosely interwoven lattice-like pattern. In scar tissue, the collagen fibres develop into clumps, and this happens in both hypertrophic and keloid scars. But like I was talking about in the last slide, keloid scars, it's a more aggravated scarring response, and they have lots of thicker collagen fibres, and they're kind of glassy when they're examined under a microscope. So they are just thicker and more aggressive. But whether it's hypertrophic or keloid, they both differ from normal skin because of their the increased vascularity, the increased cell numbers, and the thickened epidermal layer. And just one little aside, there's been some recent writings about the fact that in Asian skin types, and we will talk a little bit about this in a while when we're talking about intervention, they have a thicker dermal layer with more collagen present, which seems to explain the sort of quite aggravated scarring response. The etiology of scarring remains unclear, and we don't have time to unpack this, but if you're interested, you might actually want to do some reading about the origins of, or the etiology of scarring, because there are 4 theories, you could say: the biochemical, the immunological, the immune response, metabolic, and endocrinological, and that the consensus seems to be that they all play a role and they can be interlinked. But there is a strong case for actually all of them. So it's worth reading. If you're interested, I can certainly send you some more reading material about that. And now let's talk about risk factors. Time to healing is obviously significant, but we practically, I would say that we, in our clinical roles, we would say that there is an increased risk of scarring for people with dark skin, like African or subcontinental skin types, Asian skin types, for redheads, certainly when skin is at stretch, times of hormonal change, and also age, either the very young or the very elderly. But that seems to be a little bit of a variable feast, age, because there are considerable numbers that defy the odds. And there was an interesting article in 2016 that suggested actually the things that are there is the strongest evidence for is a young age, but again, that varies a lot. Bacterial colonization, that's logical because infection delays healing, and skin at stretch. And they also suggested on weaker evidence, dark skin. this is a reputable article, but my own feeling is it didn't quite go far enough. And very interesting comment made in this journal article is that chemotherapy and smoking protect patients from hypertrophic scar formation. Now, chemotherapy, I have seen that with my own eyes, where I've seen people who, by all accounts, should have aggressive hypertrophic scarring, but they had an amazing scar outcome. And I can only speculate that the cell toxicity of chemotherapy also affects the collagen production. The smoking, go figure, because we do know that smoking potentially delays wound healing. So that was the evidence that the conclusion that they drew from the evidence. Still, it's not strong enough evidence for me to say to patients, keep smoking, it's going to give you a better scar outcome, but it's just an interesting little thought to sort of kick around. Now, there's a journal article which I just really love for having a good understanding of scar interventions, and it's by Mohm et al, and it is called Updated Guidelines for Scar Management. And it was a collaborative venture by there's about half a dozen authors. And I have copied here the tables that they have in this journal article. And again, I'd be quite happy to send you the reference to this article. I use it when I speak to registrars, when I speak to therapists, when I'm training students. It is a very helpful guideline. And for us, when we are approaching using compression with scar management, it's really helpful to have in our mind. So it breaks the scarring down into a number of scar types. So linear, after surgery or trauma, and then it looks at what the optimal prevention is and then what's appropriate in different time frames. So prevention, this is really, this is our bread and butter. Those of you who work with scarring, you just think, I know this in my sleep, but this is a very helpful framework for us. So preventative measures, moisture massage, silicone taping, and compression. Then in the 6 to 3 month mark, we should be continuing that regime, that prevention regime, and if pressure therapy hasn't been commenced, it needs to start then. After 6 months, if the hypertrophy continues and isn't starting to abate, then previous treatments should, all those conservative management interventions should all be continuing. And it's around this time that a surgeon may be considering using corticosteroids or maybe surgical release. After 12 months, and I think my own clinical experience from burns, I would say actually we're still continuing those previous treatments, but this article refers specifically about surgical revision plus or minus those same conservative therapeutic interventions, moisture massage, silicone and compression. So now that was linear scars, so I did slightly go off on a red herring there, but because this slide talks about widespread hypertrophic scars, and it is much the same apart from the fact that a surgeon might consider corticosteroids a little bit earlier, although that is unusual, and that regime pretty much continues as we described for linear scarring. But then we look at keloid scarring. So at the start, when a keloid scar is identified, we kind of need to throw everything at it. Silicone, compression therapy, moisturising and massage. And as the keloid develops, we definitely need to be using custom-made compression garments and silicones, and quite early on surgeons would be considering corticosteroids, because corticosteroids coupled with compression and silicone is kind of the best shot at exerting some kind of control over keloid scarring. And the one thing that I would add to those of you who are maybe relatively new to scar management is one of the most important things that we can do as therapists is make sure that patients have got realistic outcomes, because keloid scarring is invasive, intrusive. If it's in a visible area, it's highly visible and difficult scarring oftentimes for people personally to deal with. But we need to make sure that we're not offering false promise, because while we throw everything at it, we need to be measured in how we explain the potential outcome. So if after 12 months we step back, although we may still be providing some of those conservative scar managements, but the medical staff are looking further afield at other interventions. Now, all of those three tables come from that Merm et al. Article from 2014, but there is another article that I think is extremely helpful for us as clinicians. It does refer to linear scarring. It was a collaborative venture between 4 surgeons: Japanese surgeon in Japan, Korean surgeon in Korea, Chinese surgeon in, actually I think it was Taiwan, not China, and then a Caucasian surgeon in the US. They did a collaborative review of scar responses in Asian skin types. And as I mentioned earlier, there's evidence about the thicker dermis. They concluded that a few things. One is that there was a 3-fold increase in the rate of hypertrophy compared to Caucasians. They, as I say, the dermis is thicker, and they identified an increased collagen density. And so therefore, Asian skin types are far more vulnerable to hypertrophic scarring. And actually, scarring can look very much like keloid scarring in that it just seems so much more aggressive. But in fact, when you look at the wound, it hasn't gone beyond the border of the wound. It's just a very aggressive hypertrophic scarring response. And this particular paper identified very strong evidence for the use of silicone products as first-line therapy, and that also that higher compression might be more beneficial. Now, in the unit that I work in, and in my clinical practice, both public and private, I've changed what I do so that now for all Asian skin types, we get silicone started straight away. Whereas previously I would have started with compression, and then if I saw a kind of a very aggressive hypertrophic scarring response commencing, then I start the silicone. But this article would suggest otherwise, and I have stepped beyond the article because it is about linear scarring, but from my reading of the article, the same could well be said of hypertrophic scarring. I hope that's kind of helpful for setting a bit of kind of a framework for our intervention. And just as a review, I suspect this is familiar to most of you on the webinar, but we have 3 key principles for scar management. One is to stretch the scar, so that's done with exercising, splinting, positioning, function. We want to soften the scar, so that's moisturising, massaging, taping, using hydrocolloids and silicone therapy and compression. And we want to compress the scar, so we use taping, bandaging and garments for that. Compression therapy is used, as I say, to flatten and soften scars, to reduce the hypervascularity of hypertrophic scarring, and we commence when the scar is immature, and we continue for 12 to 24 months depending on a range of variables. So the age of the patient's burn depth, the rate of maturation, certainly time to healing. And also I would say it varies a lot in units. If we're talking specifically about burns, it varies a lot around the units in Australia and New Zealand. Some wait until a scar or a burn is fully healed before measuring and applying compression. The unit I work in, we measure day 2 post-operative, and we aim to apply a garment on day 7 to 10. So it's a very aggressive team approach to scar management there. But I'm not saying one is right and one is wrong. We have done a study that shows that early compression doesn't have an adverse effect on healing time, But, you know, there's a range of factors to be considered in different units, and those decisions are made frequently as a team for a range of reasons. There's a kind of a key journal article by Van der Kerkhoff in 2005 that discusses sort of the theory of compression, and it poses the fact that for compression to be effective for scar management, the pressure needs to exceed 24 millimeters of mercury to overcome capillary pressure. I'm going to come back to that in a sec, but our general practice is 25 to 30 mils mercury for burns and scarring. There is also evidence that if we apply compression at too high a level, 30 to 40 or even higher, it causes problems because it can cause paresthesia or maceration. And there's also evidence that it's ineffective if it's under 10 millimeters of mercury. Now, here's the kind of little tricky thing. Garments for limbs must apply graduated compression because we're not applying compression for scar management in the void. We are applying it, obviously, to a living, breathing human person with a circulation system. And we do know that we need to support the return, venous and lymphatic return, and so therefore compression must be graduated. So it's higher at the wrist and higher at the ankle. And for a kind of a more far-reaching consideration of the patient, we would target the ankle compression at somewhere between 28 and 33 millimeters. But in the wrist, it's proportional to ankle compression. So in fact, we're applying routinely compressions 14 to 17, maybe 20 millimeters of mercury at the wrist. And that kind of doesn't tie in with the exceeding capillary pressure. So we do have this, we still have split evidence about the benefits, but we do know for holistic compression, we generally go for 30 millimeters of mercury at the ankle, and it still proves to be beneficial even though the compression is graduated. That might be something you want to ask a question about at the end. If you're having trouble getting your head around that, we can certainly discuss that further. Little quick aside about graduated compression in case it's unfamiliar to any of you. Graduated compression is highest at the ankle and it decreases up the leg. So it supports the vein wall and the lymphatics so that it supports return from distal to proximal. And those of you might have come across the law of Laplace, where if something's applied at constant tension, it automatically graduates as a circumference gets larger. All right. Now, so when you have to prescribe the correct compression, I will just want to highlight a couple of things. It's your responsibility. So you're the clinician, and the staff at the factory, awesome as they are not clinicians. They are highly experienced designers or highly experienced seamstresses, dressmakers, so you need to make that clinical decision. However, in the case of burns and scarring, we automatically calculate it at 30 millimeters of mercury. But as I said on that previous, or 2 slides ago, it does vary between the lower and the upper limb, but you can change it. So I just want to show you when you have 25 millimeters of mercury at the ankle, what that means is at the wrist or on the forearm, it actually starts at about 15 millimeters. It's slightly looser at the wrist to avoid tourniquet at the wrist. It reduces again at the elbow, it then goes up for the forearm, and then again it's reduced compression at the end. This might be an interesting slide for you to kind of hang on to because it just shows the progression based on different requests for millimeters of mercury. And also it's probably helpful for you to be aware that We do a standard reduction of compression for over 70-year-olds for basically their safety and to ensure we don't create any other health issues. So when do you apply compression? Well, it's based on time to healing and the surgical intervention. I would say the scarring community generally works on, if it's under 14 days that a wound heals, unlikely to need compression. If it's over 21 days to healing, definitely needs compression. And if they've had surgical intervention, sorry about the typo, then compression's also required. But that 14 to 21 days, this is where your clinical judgment comes into play. You look at the vascularity, you look at the inflammatory response, and also you assess for any other risk factors that we've discussed already. And for me, if I had somebody, say, with an Asian skin type and they healed in sort of 14 or 15 days, I might take their age into consideration, some other things. I'm more likely to treat them as a more than 21-day healing on balance of probability, because I would rather be proactive rather than say, look at them at, say, the 3-month mark and just think, I should have done something. And it's not that that ship is entirely sailed, but it's certainly heading out of harbour. So we start compression as the wound management phase is concluding. So commonly wounds, garment wear starts when wounds are near healed, possibly in low profile dressings or possibly entirely healed. As I mentioned earlier, measurements can be taken as early as 2 days post-op, but the swelling has to have subsided, otherwise you're obviously not going to get a good fitting garment. So when is a custom made essential? Because we all work in health and we all know that health is under fiscal pressure, but it's essential when patients don't fit ready-to-wear garments. That can be their circumference, their height, their limb length, or their proportion. And what I often say is that if a patient doesn't fit the sizing chart on a ready-to-wear box, they don't fit. It's not like going and buying yourself a pair of jeans where you're an 8 on your waist and a 12 on your hips and you think, oh, I could do a 10, it'd be a little bit loose on my waist and a little bit tight on my hips, but hey, that's probably a good thing. You know, all that kind of, we can't do that because we put people at risk. We compromise the graduated compression and we also compromise the efficacy of the garment. So custom made is also essential when a patient's an odd shape. That refers to the proportion. Maybe where an accurate fit or compression is required, where we really want targeted compression, possibly when we're wanting to apply higher levels of compression, like I mentioned in that article that suggests that Asian skin types might benefit from higher levels. When a suitable style is not available, and I'm sure we've all been there. And also when we just need to change designs and the design that we need a whole bunch of other options and modifications introduced. So why would you choose Jobskin? Well, I would say it's because you can get what you want. The garments are fully customizable. There is a huge range of compression, 20 to 70, but can I just say you would not be applying 70 millimeters of mercury for scar management. Obviously, that's looking more at the edema and the lymphedema ranges. The compression is graduated. It can be made for any body part and for any size, from tiny babies to extremely large adults. And actually, if you're interested in the extremely large adults, that you'll find a lit review on the website about compression and obesity for burns and scar management, so that might be something that you might like to have a read of. Also, Jobskin offers some custom scarring solutions, most notably Cylon Tex, which we're going to talk about. That's a silicone lining that can be stitched into the garment, which is just awesome. And then also we offer a huge range of resources. We provide clinical support. The designers are only too willing to help you troubleshoot any challenges that you have with designing a garment, and Veronica and I are only too happy to help you troubleshoot clinical situations. And we offer, as you know, training workshops and webinars, because here we are. But also I'd refer you to the website because there's training videos for everything that you could possibly think to measure. We've got brochures and guidelines, and there's forms, newsletters, there's some evidence for compression, evidence articles or journal article reviews you'll find. Just on the right there, there's a graphic of the Why Jobskin brochure, which we'd be happy to send out to you, or you can download off the site. A quick little aside, Jobskin does do ready-to-wear gloves. They're made out of the same power net that we use for our garments. They're useful as a light functional support, certainly a great interim garment. They're suitable for edema control, and they are thenar eminence free, so that they are bilateral. You can use them on right or left. If you do need specific support around the thenar eminence, you do have to go custom, but they're a really good cost-effective alternative to custom garments, and they're very easy to measure. Basically, it's a palm measure and a wrist measure. Okay, now let's talk a little bit more about custom-made garments. As I say, they can be fabricated for anywhere on the body, and our design team use varying weights in their fabric. So when you request a certain level of compression, they are going to look at the size and proportion of your patient. They're going to look at the compression that you want, and then they will choose an appropriate, what's called gram tension weight of fabric. You don't have to do that, but sometimes if you have a patient who's probably particularly tough on garments, maybe they work in the mines, or a small child who's, scoots around on their bottom, they might benefit from a higher gram tension weight of fabric because it's a little bit more durable. As I said before, we do encourage you to collaborate with the designers because they will really help you come up with the best possible garment. And the options and modifications that I referred to allow for an accurate fit, and we're going to look at a few of those. Modifications that make garments easier to put on or take off. We can certainly allow patients' preferences to be accommodated, and some of you may have heard me give this example before, but I had a patient who was a mad keen Dockers fan. Those of you who follow the AFL, I make my usual joke in the footy season about, garments look really good with purple with white stitching, and I had one young bloke who had to wear a sock say, "Oh, could I really get that? And would they do 3 white V's for me?" And I said, "Well, we can ask," because that's, those of you who are not footy followers, that's similar to the Guernsey design of the Freo Dockers. And the garment did come back with 3 white V's stitched on it, and he was just so motivated to wear that garment, and that's what we want. So there's colour and style choice, that's obviously tied up with that. Compression levels can be varied within a garment. We can target specific areas for compression. We can include linings to protect fragile skin, and we can accommodate silicone products or dressings. And obviously, if people like the garment and if it's aesthetically pleasing and they can get it on and off and they can get it off quickly to go to the toilet, all those things, they're far more likely to comply with it. So how does this work? Those of you who are not familiar with Jobskin, we train clinicians in garment measuring and prescription. COVID and the reduced movement around the country has made it a little bit more difficult, but we are endeavouring to do that through webinars, but also, as I say, on the website, there are measuring videos for every possible body part. And I actually did a visit this morning to a clinician, and it was the first time she was measuring for waist-high tights. And I'd said to her, do you want me to measure one leg and you measure the second leg, or how do you want to do this? She said, no, I've watched the video. I think I'm all over it. And she was all over it. And she felt like she needed feedback to say, am I doing it right? But she was quite confident in the way she approached that. So that's a helpful encouragement for you, I think. After the measurements are taken with our paper tapes, you can see in the bottom corner those colours have been changing. That sort of murky green one is now a gorgeous purple, which you'll see a little bit later. The measurements are transferred to the form, and then it's you prescribe the garment. We'll talk a bit more about that, and then you send that off to our customer service division. Now, a quick thing, how do you read the tapes? because that's a question I get asked a lot. I'm sure Veronica would say the same. What I've done here is I've wrapped this around an upper limb, and then you can see those angle cuts at the top. I've now cut the tapes off, and this is what a tape looks like when it comes off the arm. I've marked left or right, always a good tip. But where do you actually read the measurements? It's right along that line there. So if we look at that close up, you can see the numbers. If I use my cursor here, let's say if we're looking at this purple tape, we'll put an arrow of this tape here. Or actually, now it's going to look over here. So these numbers in circles refer to centimetres, and each one of these lines is 2 millimetres. So for this one, we measure along that straight line. So that would be 2, 5, and then how many millimetres? 2, 4, 6. So that measurement is 256 or 25.6. On the forms, you don't have to put the decimal point. There is a slightly thicker black line that acts as a decimal point. We always fill from the right, but that is 25.6. And that one would be 24, 2, 4, 6, arguably 7, so 247. All right, so now there is a really great brochure that is we'd be happy to send to you, or you can download from the website, which is about prescription guidelines for patients with burns or scarring, because Jobskin garments can be used for a range of clinical indications, but you, and particularly if you're less experienced, you want to make good decisions and make sure your garment's doing everything you want to do. And sometimes it can be a bit overwhelming. But if we just look at the inside of this brochure, it talks about the things you need to consider. Whether edema is present, is the skin fragile or prone to breakdown? Then it offers you some solutions about the way that you can modify a garment. And these are certainly the things that Veronica and I are happy to chat through with you. Is there an increased risk of a poor outcome? For example, do they need silicone, and would they benefit from having Cylon text sewn into the garment? How severe is the hypertrophy? Are there lifestyle or environmental factors that will affect the patient's ability or willingness to wear the garment? I've got this really awesome example for a Chinese chef who I've been seeing, or I am seeing currently, and he slipped when he was carrying a pot of hot oil, and it spilled back over his face. Now, nasty burn, needed debridement, but didn't have skin grafts or RECELL, but an Asian skin type. So it was just like a bit of a kind of perfect storm. Unfortunately, here's another factor in the perfect storm. He had 2 jobs. And the job where he sustained the injury, it was compensable, that wasn't an issue. But showing up to his other job, he felt that it was an issue, and he felt that there's no way his boss would allow him to wear a face mask. But I was looking at the risk factors and the clinical presentation thinking, if we don't get compression on here, this is so not going to work. We tried all sorts of things, but in fact, what we ended up coming up with, it's a compromise solution without question. But a broad headband in black. So it goes, if you can see me, it sort of goes around the forehead like this. He thought it looked awesome because it actually looked quite chefy, for want of a more technical term. And that was such a good example of the environmental factors. Like, there's no way he was willing to wear a garment, but we came up with the next best thing, and he can wear his face mask when he's not at work. Then we also need to consider people putting on, or can they take the garment on? Can they put it on? Can they take it off? And are there any design features that will be helpful to, for children particularly, if you made it red and blue so it looks like Spider-Man or Wonder Woman or whoever, then someone's far more motivated to wear it. So they're all the things that you can consider, and I would encourage you to either download or get us to send you one of those and make it your little scar management Bible, because it's really helpful on the side. So let's talk a little bit about Cylon text. This is fabulous technology because it is only 0.5 mil thick and it can last 6 to 8 months. I have to say, as a clinician, I was highly skeptical about whether this would last the life of a garment, but I have been proven wrong time and time and time again. It's sewn into the garment, it conforms well, and it's suited to contact over small circumferences like fingers and toes, or, you know, under chins, or over, you know, small patches. It is so user-friendly for patients. Now, I just wanted to go through a few handy hints for scar management that you might like to consider. I'm just being reminded about the next webinar coming up. When you're doing a glove, you need to consider standard versus slant inserts. I don't know if you can see this, but the web spaces don't come as far back down on the dorsum as they do here, and this is because the way these are constructed. Basically, the gusset that goes in the web space between the index and the middle finger for the purple one is just a straight piece of fabric that's folded in half, and so it goes straight across the web space. But if we want it to nestle down into the web space because we need compression there, you're better off choosing something that's made with an L-shaped piece of fabric, because when that's folded in half, it's angled, and so it angles back into the web space. When you've got scarring risk in the web spaces, that slant inserts are an absolute essential, and if you wait till the scar and therefore the web creep starts, you've missed the boat, and a slant insert won't do its job. It'll actually just push it'll make for a compromise fit. Another little hint is the Axilla styles, and if you've been on previous webinars, you might have heard this before, but one thing I just wanted to highlight here, can you see that with that normal gusset, it's sort of loose across the Axilla, and that's quite comfortable. But if you need that fit to go right up in there, you need what we call the Irish Axilla. And I'm seeing a patient currently who's got scarring on the upper arm and scarring on the chest wall right up into the axilla, and if we put, but not across the anterior of the axilla, if we put this on, they're just not going to get adequate compression, but this gives a beautiful fit. So another little hint to bear in mind. When you are doing anything around faces, a few things to be mindful of. This what's called the contoured nose covering gives you really good fit either side of the nose. And this is called this is here just normal, I just can't think of the name, a lycra turtleneck fit. But if you have a look here, if it's made out of the 5 centimetre wide elastic, and I'll just show you on the next slide, here that is elastic, and it fits really nice and flat. Because these are on mannequins, this is the scoop neck, and it's sort of a little bit more scooped here. But if you need compression over here, it's going to sit away from the neck. So you need to go to the turtleneck option. And while it just sounds hideous to put elastic around someone's neck, it's actually a bit more like a hug. They're far more likely to find this more comfortable than this seaming and possibly elastic at the top, because that feels a bit more choky. So that's another little hint of the day. Another trouble area for scarring is the sternum. And because we've got a natural concavity there, and you couple that with the natural concavity around the sternal notch, it's very hard to get compression. So you can use, this is like called an Adonis, it's a reinforced Adonis vest that you can use for men, or you can have a sternal strap. This is can be used on men or women, and that can also be stitched into a garment. For women, between the bra cups, for men just into a normal vest. And this little one, this is once you see this, you'll go, oh, this is obvious. Why? And I apologize for the poor images, but if you have a look, that little area behind the malleolus is a real concave spot, and what we normally is we do put a sock on, and you get beautiful compression everywhere except behind the malleolus and under the malleolus. And I've seen people who that's where the scarring is, and they've got lovely compression everywhere except where they need it. But there's a very simple solution, and that is that we stitch in some foam in that L shape, which you can also, this particular, I think it was this patient, or if not, it's a similar patient, we stitched Cylon text onto the inside of that foam so that they had direct contact with silicon from the Cylon text. Then the foam, which meant that the pressure was transferred through, that became that went from an inadequate garment to a highly effective garment. Now, we're just going to finish with a couple of case studies that will help you understand the scar management process. This was a 43-year-old man, actually Asian skin, lived with his, works FIFO. He was a 70% burn, so actually his hand was probably the least of his worries, but this is kind of a contained example I can give you for the use of Cylon text. He had extremely aggressive hypertrophic scarring, and this is him well down the track. His hands were largely spared, but he did have aggressive hypertrophic scarring over his thumb. It's a tricky area to get silicone therapy because gel sheets roll up when you put a glove on. Silicone putties are very bulky and they're not malleable, so you can't move properly. So what we did for him was we gave him custom power neck glove, and Cylon text was stitched in to the thumb. So you can see it showing there, and this is it turned back so you can see what it looks like. You can see how incredibly thin it is. Oh, sorry. And he didn't need slant inserts because his web spaces weren't affected, but actually purely by having custom garment with the Cylon text stitched in, he had a highly effective garment. Now this next patient, sorry, my slideshow's taken a life of its own here. 43-year-old man had a high voltage electrical injury which had grafting and flaps, and this is him well down the track, close to maturity. But what we did for him was the compression needed a number of things. We needed scar management for the split skin grafts. We needed compression over the free flap to help with the shaping and to control any development of chronic edema. And we also wanted to enable hand therapy in his return to work. So we put him in a gauntlet to Axilla, and we had to consider the anchorage versus the donning, and we put, it's not very clear on there because it's a black gum, but we actually placed the zip to avoid the flap because we didn't want to compromise the compression, and it's also not very clear on that, but we also had a panel from the thumb into the palm to encourage opposition because he was actually sitting, you can see that he's sitting quite flat out there because of the nature of the injury. So very quick, I've really rushed those, I'm sorry, but we've got just 5 minutes or so before the next session of this starts. So I do apologise, but very quickly, has anyone got any questions? Really happy for you to ask questions, and if you are not confident to ask in the webinar, then by all means you can email them through. I've either completely bamboozled you or equipped you if you don't have any questions, but you're very welcome to email questions through to us after the webinar if things come to mind after our conclusion now. And just as we wrap it up, if there aren't any questions, and Veronica can confirm for me whether there's any questions that have been typed, quick reminder, if you haven't put your email in for your PD certificate, just do that in the group chat now. All right. Thank you for joining us, and we hope we see you at the next webinar. The next webinar, I believe, is on the head and neck, which is often one that people find intimidating to measure, but I assure you, it's not as intimidating as it feels. So we'd love to see you then, and we can help your confidence with that.
Just on
Can I hand over to you, Veronica? Or Adam.
Yeah. I've also included our YouTube channel in the chat. So for a limited time, we've opened up all past webinars, and they're all available on our YouTube channel as well. So you can visit them at your leisure.
Thanks everybody for being here.
Thank you.
Bye then.
Thank you.